Well, is chronic liver disease, do you consider it a big section or a small section? Well, the way that we are going to do it with you, it's a small section. The way it is in your mind, chronic liver disease is enormous. For us, we can see it as a small section because no matter what the cause is of chronic liver disease, there's a lot of things in common. The lot of things in common are that you have a low albumin. No matter what the cause is of chronic liver disease, there is a low albumin because your liver is synthetically abnormal. I saw a patient over the weekend, and we were like, oh man, he's got cirrhosis, he drinks a lot, he's signed out of the hospital, he's a homeless guy who his basic 4 food groups are vodka, whiskey, beer, and wine. And his albumin is normal. His prothrombin time is normal. So when you want to assess liver function, the liver function can't be assessed by the transaminases, the prothrombin time, the albumin level, due to normal prothrombin, normal albumin. God loves you, and so do we. So when you see these things, all forms of chronic liver disease damage your ability to make albumin. What can you do about it? The answer is there is no specific therapy. What do you do about the high prothrombin time? The answer is nothing. But if you're bleeding, we give you fresh frozen plasma. Now that's all forms of chronic liver disease. That's whether that's alcoholic liver disease, whether that's alcoholic liver disease, there is no specific test for alcoholic liver disease. There is no specific therapy for alcoholic liver disease. That's it, you're cooked. High prothrombin time, low albumin. You have a person who's got neurological dysfunction. They've got asterixis, and especially if they've got encephalopathy, or some of you say encephalopathy. Well, what do you do about that? Well, the answer is you have something to do. Lactulose, right? Faximin. Not neomycin. Neomycin, old crap, black and white television, 8-track tape player, cassette tapes. Rifaximin, lactulose. Lactulose damages the ability to absorb ammonia because lactulose makes it so you can't absorb ammonia from the bowel. Rifaximin kills off the bowel's flora so you don't reabsorb those bacteria. So the neurological dysfunction, at least you can do something. What do you do about the edema? Not too much. What do you do about the ascites? Well, the answer for the edema and the ascites, spironolactone. Did you know this is the best diuretic? Now, if I asked you why, the average medical student says, because it's a potassium-sparing diuretic. Now, spironolactone may have been invented as a potassium-sparing diuretic, but that's not actually why we use it. We don't use it because it's potassium-sparing. We use it because people who have cirrhosis have a low albumin. People who have a low albumin have decreased intravascular volume. And people who have decreased intravascular volume have a high aldosterone state. So spironolactone is for people who have decreased intravascular volume and have high aldosterone states. And spironolactone lowers the aldosterone. And you can use furosemide, but furosemide is not as specific as spironolactone. Now, ascites is extremely important because the first thing we got to do is got to tap that ascites. Got to tap that ascites, and we have to see, hey, first of all, spontaneous bacterial peritonitis is people have above 250 neutrophils. You have a person who's got ascites, you want to be able to see if they have above 250 neutrophils because you want to be able to see whether or not they have an infection that needs cefotaxime, ceftriaxone, cefotaxime, ceftriaxone, because it's spontaneous. Now, one of the reasons we call it spontaneous is because we really don't know how it happened. We call something spontaneous when we really don't know why it happened. In other words, how did this happen? How did the bacteria get in there? I don't know. It's not like there's a hole inside the bowel wall. It's not there's a hole. It just leaked across. How did it happen? Spontaneous. Spontaneous, idiopathic, primary. Well, spontaneous bacterial peritonitis happens because bacteria leak across. And you do have E. coli, and you do have strep pneumonia. You don't have anaerobes. This is a very strange thing. Why don't you have anaerobes? Why don't you have anaerobes in there? Well, we don't know. Why do you have a lung bug like pneumococcus? I don't know. That's why you're using cefotaxime and ceftriaxone. If it looks like the drugs that you use to treat pneumonia, it's because it's the drugs that you use to treat pneumonia. Why does spontaneous bacterial peritonitis give you pneumococcus? Why doesn't it give you anaerobes? Walt Whitman says, a child comes to me with hands full, saying, what is the grass? How can I answer the child? I do not know any more than he. I don't know why it happens. I do know that it's very important to be able to tell the etiology of things. It's very important to be able to tell the etiology. Do you have a serum to ascites albumin gradient less than 1.1? Do you have a serum to ascites albumin gradient less than 1.1? Serum to ascites albumin gradient less than 1.1 means the fluid acidic albumin is very high. And when the fluid acidic albumin is very high, it means that there's a lot of cancer in there, or major infection, or tuberculosis, or cancer, because when the gradient, the difference, is very low, it means that there's cancer, because cancer gives a high acidic fluid albumin. Cancer gives a high acidic fluid albumin. Why is it that? Well, it is. But when you have a serum to ascites albumin gradient greater than 1.1, SBP, transudate, portal hypertension. Portal hypertension. And that's the most important thing. I tell you that if you asked me, Conrad, what is the single most important fact that your test wants you to know about ascites, is that they want you to know that how do I tell whether it's infected? Because the PMNs is high and you need to use cefotaxime and ceftriaxone. And I want to know, is it portal hypertension? In other words, is it congestive heart failure, portal hypertension? And then the serum to ascites albumin gradient is high. It means the acidic fluid albumin level is low. The acidic fluid albumin is low. The acidic fluid albumin level low means the gradient, or the difference. The gradient or the difference between the serum and the ascites is big. SBP, portal hypertension. So what are the two things I want to know about ascites? Is it infected? And is it portal hypertension? Is it greater than 250 neutrophils? Is the acidic fluid albumin level low? Now, there's two ways to get tests. One is, hey, I don't know what's there. Let's get a bunch of tests to see what's there. Let's test them and we will see what's there. Let's get them on tests, see what's there. And the other way is to say, I'm getting the paracentesis to say, is the neutrophil level high? I want to give antibiotics. Is the albumin level low in the acidic fluid? That tells me that it is portal hypertension. And that's what I'm getting these tests for. I'm getting the tests. You notice I never told you to do an ammonia level. I never told you to do an ammonia level because ammonia levels don't correspond with what the level of hepatic encephalopathy is. If you have confusion and disorientation, you need lactulose, you need rifaximin to kill the bacteria in the bowel. But I didn't say, hey, follow the ammonia levels. Either your ammonia level is high, but you're like, E equals MC squared. The square of the left and the right side of a square right triangle is equal to the square of the hypotenuse. If you're doing the old Pythagorean theorem there, doesn't matter what your ammonia level is. What matters, are you confused? Edema, spironolactone. Ascites, spironolactone. Next, gynecomastia. What are you going to do about that gynecomastia? What are you going to do about the gynecomastia? I don't know. Victoria's Secret catalog? Push-up bra? I can't do anything about it, but we can make them more attractive for you. And there's nothing to do about the gynecomastia. Pulmonary erythemia? What can you do about it? Wear gloves? Okay. Spider angiomata? What can you do about it? Hepatic encephalopathy? You could do something about it. Lactulose rifaximin. Bleeding from renal insufficiency, bleeding from hepatic insufficiency, you could do something about it. You can give fresh frozen plasma. Why not vitamin K? Because the clotting factors are made in the liver, so even if you give them vitamin K, it's not going to work. Now, what I've done for you here in this long section, 6, 7, 8 pages, is say, this is primary biliary cirrhosis, primary sclerosing cholangitis. This is alcoholic liver disease. This is chronic hepatitis B and C. This is alpha-1 antitrypsin deficiency. If you have disease that's bad enough to cause cirrhosis. I'm telling you that cirrhosis, there's nothing to do about the spider angiomata, the pulmonary erythema. There's nothing to do about the gynecomastia. You can do something about the bleeding, fresh frozen plasma. Vitamin K won't work because the clotting factors are made in the liver, and giving vitamin K won't work. You can do something about the encephalopathy. What else can you do something about? You should scope all of these patients because you want to know whether there are varices. And you want to know whether there are varices. You want to know if there are varices in order to know whether to give beta blockers, in order to know whether to give propranolol, in order to know whether to give propranolol. I never said use banding empirically. Banding if someone bleeds, yes. But empiric banding is considered controversial at this time. Some people say yes, some people will say no. But beta blockers to prevent the bleeding is good. Which form of GI bleeding has the highest rate of mortality? Which form of GI bleeding has the highest rate of mortality? And the answer is variceal bleeds. So we want to prevent the first episode of mortality because it is the most dangerous of the mortalities. Next, let's go into the specifics. Alcoholic liver disease, there's no test, there's no particular treatment. Next, chronic hepatitis B and C. Chronic hepatitis B, chronic hepatitis C. There is therapy for those, for sure. Big subject. So big, in fact, that this course and this book covers it twice. There couldn't be anything more important than chronic hepatitis C because chronic hepatitis C is the most common reason to need a liver transplantation in the United States. So what could there be more important? There's 4 million people with chronic hepatitis C. Everybody who's born between the age of 1945 and 1965 should be tested. Doesn't matter what their risk factors are. Everybody with chronic hepatitis C should be getting leadipasvir and sofosbuvir. Everybody should be getting maybe the ribavirin, red cells, ribavirin, red cells, and anemia. But chronic hepatitis C is the only form of acute hepatitis that has treatment, because 80% of people with hepatitis C that's acute go on to chronic hepatitis C. Chronic hepatitis C, why? Because it is the most common reason to need a liver transplantation in the United States. Ribavirin may not be useful, first of all, but all of these are oral medication. Leadipasvir, sofosbuvir. Now you are current. Oral therapy doesn't need interferon. Oral therapy doesn't need interferon. How are you going to tell the response to therapy? PCR. PCR for the RNA of hepatitis C. PCR for the DNA of hepatitis B. PCR for the RNA of hepatitis C. PCR for the DNA of hepatitis B. PCR for the RNA of hepatitis C. PCR for the DNA of hepatitis B. Whoop, whoop, whoop. Hepatitis B is monotherapy. Hepatitis B, lamivudine alone, entecavir alone, adefovir alone, lamivudine, telbivudine, entecavir, one drug alone, lamivudine, entecavir, telbivudine, tenofovir alone. It's not clear that you should get combination therapy for hepatitis B. It is clear that you should be getting combination therapy for hepatitis C. Hepatitis C therapy. Now, there's been a lot of changes here. First of all, hepatitis C management. You test everybody, even if they say they have no risk factors. I never shot drugs. I don't sleep with anybody. I'm a virgin who never shot drugs. Doesn't matter, get tested. Combination therapy. You notice interferon is missing because interferon sucks. How do I tell the response to therapy? PCR for RNA. When do I answer liver biopsy? You answer liver biopsy if the question says, which of the following tests is the most accurate way of telling you the stage of the liver disease? How much liver disease there's been? What is the effect and the damage on the liver? That's when you answer liver biopsy. How do you tell the response to therapy? Did the viral load go down? Did you achieve sustainable viral load detection? The viral load is undetectable? You fixed it. There's nothing to do for alcoholic liver disease. Nothing to do for alcohol. Let's do the easy ones. The easy ones are this: primary biliary cirrhosis, primary sclerosing cholangitis. Primary biliary cirrhosis and primary sclerosing cholangitis are easy because there's very few data points for them. First of all, generally speaking, for both of them, the bilirubin can be normal. Generally speaking, for both of them, they both can have a high alkaline phosphatase. Generally speaking, for both of them, they have a high alkaline phosphatase. The bilirubin can be normal. Primary biliary cirrhosis, primary sclerosing cholangitis. You'll be able to know it's primary biliary cirrhosis because it'll say xanthelasmas. And you'll know it's primary sclerosing cholangitis because it says irritable bowel syndrome. Irritable bowel syndrome. MRCP, ERCP tells you that there's beatings or strictures of stenosis. Beating or strictures of stenosis for primary sclerosing cholangitis. Beating or strictures of stenosis. They both get treated with the same thing, which is cholestyramine and medications to block the production of bile acids, urso or chenodeoxycholic acid. Ursodeoxycholic acid, chenodeoxycholic acid, these block the production of bile salts. Well, how will you tell them the difference also? Primary sclerosing cholangitis is the only form of liver disease in which the answer is not biopsy. The answer is a magnetic resonance cholangiopancreatography, endoscopic retrograde cholangiopancreatography. Generally speaking, this is the diagnostic test. ERCP is therapeutic. MRCP is the diagnostic test. ERCP is therapeutic. Xanthelasmas could be of both of them, mostly with primary biliary cirrhosis, and anti-mitochondrial antibody for primary biliary cirrhosis. Anti-mitochondrial antibody for primary biliary cirrhosis, MRCP and ERCP for primary sclerosing cholangitis. Now, they're similar in the sense that both primary biliary cirrhosis and primary sclerosing cholangitis are incurable, itchy, high alk phos. Give me some cholestyramine and ursodeoxycholic acid to block my bile production in this shitty, incurable disease that I don't know what to do with. Well, what's different then? Primary sclerosing cholangitis is the only thing in the liver for which biopsy is not the most accurate test. Ultimately, the most accurate test for alcoholic or chronic hepatitis is biopsy to look at the liver. Ultimately, the most accurate test for hemochromatosis is a liver biopsy for stainable iron. Ultimately, the most accurate test for Wilson's disease is a liver biopsy for that copper, liver biopsy for copper. Ultimately, the most accurate test for autoimmune is to biopsy people. Ultimately, the most accurate test for all liver disease is a biopsy to see what's inside the liver. Except primary sclerosing cholangitis. The most accurate test is an ERCP and MRCP to see the ductal structure. Ultimately, the most accurate test. What is the most likely diagnosis? What is the best initial test? What is the most accurate test? What is the best initial therapy? What is the most effective therapy? Autoimmune hepatitis. I'm doing an ANA. Autoimmune hepatitis. Anti-smooth muscle antibody. Autoimmune. Give steroids. Autoimmune. Give steroids. Wilson's disease. We have movement disorder and psychosis and emotional lability. We have a movement disorder and psychosis and emotional lability. We have an emotionally labile psychotic Korean. The liver style. So we have Wilson's disease. We got a movement disorder, psychosis, emotional lability. Most accurate biopsy. Most accurate is a biopsy. Wilson's disease. Copper's accumulating in your brain, giving you movement disorder, and, well, I thought all liver disease could give you neurological problems. All liver disease. Cirrhosis can give you neurological problems. Give me some lactulose and neomycin. Ooh, rifaximin is better. Give me some lactulose and rifaximin. Some lactulose. So what's the difference between this psychosis and the emotional and the neurological problems of anybody with chronic liver disease? Because the average person with cirrhosis and chronic liver disease and neurological problems is like this. Cirrhosis. This is cirrhosis in general. Whether that's cirrhosis from a person with hemochromatosis or autoimmune or alcoholic or chronic hepatitis or alpha-1 antitrypsin deficiency. But Wilson's disease is different. Wilson, are you talking to me? Wilson's disease, the different, are you looking at me? Are you downloading me? Are you downloading me? Are you watching me over your keyboard? Sorry. I love you too. Excuse me. The difference between, stop staring at me! The difference between Wilson's disease and hepatic encephalopathy is that Wilson's disease is schizophrenic. They're delusional. They're hallucinatory. Wilson's disease, there's a difference between hepatic encephalopathy and you talking to me? Are you talking to me? Are you talking to me? There's nobody here. Wilson's disease is psychosis. It's paranoia. That's different than saying just encephalopathic. Wilson's disease is diagnosed. Kaiser-Fleischer rings is first and more important because looking just for a low ceruloplasmin level, just looking for a low ceruloplasmin level won't tell you you have Wilson's disease. Any form of chronic liver disease gives a low ceruloplasmin because ceruloplasmin is made in the liver. Biopsy is the most accurate. Zinc and trientine and penicillamine removes the zinc and the copper, removes the copper. Zinc, trientine, penicillamine removes the copper from the body. Wilson's disease, movement, psychosis, liver disease, Kaiser-Fleischer rings. Wilson's disease, did you know that you get hemolysis? You get hemolysis because copper causes hemolysis. Wilson's disease, most accurate test of biopsy, Wilson's disease. You give zinc and trientine and penicillamine and see how much copper goes out into the urine. Are we excreting more copper when we give you those drugs to get it out of the body? Movement disorder, psychosis, emotional lability. All of these can cause cirrhosis. All of these can cause ascites. All of these can cause portal hypertension. All of these would need scoping to see if you have varices for propranolol. All these can cause a bleeding disorder, give them fresh frozen plasma. All these can cause ascites, give them spironolactone. All these can cause SBP, get a tap and see if there's 250 neutrophils. So what is different about all of these? Well, it's like alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency is very simple. COPD in a young non-smoker with liver disease. COPD in a young non-smoker with liver disease. COPD in a young non-smoker with liver disease. What's the most likely diagnosis? Alpha-1 antitrypsin. What's the therapy? Give alpha-1 antitrypsin. Do you know you can actually replace alpha-1 antitrypsin? Did you know you can actually give it? You can actually give alpha-1 antitrypsin? Most people don't know that. Do you know you can actually give alpha-1 antitrypsin? Most people don't even know. Just give alpha-1 antitrypsin. Just give alpha-1 antitrypsin. Just give it. Almost done. Hemochromatosis. Now, most hemochromatosis is not from overtransfusion. Hemochromatosis is an abnormality in hepcidin. It's an increase in iron absorption. It's an increase in iron absorption. Hemochromatosis, it's an increase in iron absorption. It's an increase in iron absorption from the bowel. Hemochromatosis, an increase in iron absorption from the bowel. It's an abnormal set point in the duodenum, and the iron builds up inside your liver because you're overabsorbing. It absorbs and it accumulates inside your heart because you're overabsorbing. You have a abnormality and a genetic mutation. You have a genetic mutation and it deposits in your joints with calcium pyrophosphate deposition disease, and deposits in your skin because you have malabsorption. You're absorbing too much iron. You have C2A2Y. You're absorbing too much iron and it deposits in your pancreas. You're absorbing too much iron and deposits through your body. you're absorbing too much iron and it deposits in your liver, your heart, your skin, your joint. You're absorbing too much iron because hepcidin is abnormal because of C282Y abnormality. You could see it on MRI. MRI finds all that iron. You can find all that MRI, the iron, and you deposit in your pancreas and your skin and your joint, and you get diabetes, and you get 2 tiny little iron testicles instead of nice, soft, squishy, normal, tasty testicles. You get 2 little tiny iron nuts instead of nice, soft testicles. How do you die? How do you die of hemochromatosis? How do you die of hemochromatosis? How do you die? How do you die of hemochromatosis? Most people are wrong. If I asked you outright about hemochromatosis with iron absorption, you won't have a problem with knowing it's iron absorption. You won't have a problem with knowing that liver biopsy is the most accurate test. You won't have a problem with the treatment because it's not deferoxamine, it's phlebotomy. Some people get that wrong. But phlebotomy gets rid of a much higher volume of iron. Phlebotomy gets rid of a much higher volume of iron than deferoxamine, deferriprone, deferriprone. Gets rid of much more iron than chemical compounds like deferoxamine, and I don't need a needle in my bowel, in my guts, in my anterior abdominal wall. Hemochromatosis, most of the time, 100 to 1, is not from overtransfusion. Hemochromatosis, most of the time, is from a genetic abnormality making you absorb too much iron in your duodenum. Hemochromatosis is from too much iron absorbed in your duodenum and deposits in your liver, your heart, your skin, calcium pyrophosphate in your joints, pancreas giving you bronze diabetes. Hemochromatosis, the most common cause of death, 85% is liver. If I walk into a group of medical students and I want to play a game with them and say, I'm going to make you wrong, I ask them, what's the most common cause of death in hemochromatosis? And 70% of the room says heart, restrictive cardiomyopathy. I know that. That's one of the games I play. So one of the things about coming to see us here in this course is I know where you're going to be wrong before you're wrong. So if you didn't come here, you would say heart disease. Heart disease is only 15%, whereas liver is 80% of deaths, 60% cirrhosis, 20% hepatic cancer, 60% cirrhosis and 20% hepatic cancer, 60% cirrhosis and 20% hepatic cancer, and heart disease is only 15%. And I know why you would say heart disease, because you're thinking of restrictive cardiomyopathy, sarcoid, amyloid, hemochromatosis, cancer and fibrosis, sarcoid, amyloid, hemochromatosis, cancer and fibrosis. I know why you're thinking of restrictive heart disease. What causes restrictive heart disease? Sarcoid, amyloid, hemochromatosis, cancer and fibrosis. But it doesn't mean it's the most common cause of death. It just means that's what causes restrictive cardiomyopathy. 60% cirrhosis, 20% hepatoma. Treat with phlebotomy. The most important test at first is that you see an increased iron and increased ferritin. It's exactly the opposite of iron deficiency anemia. Increased iron, increased ferritin, decrease in the total iron binding capacity. Increased iron, increased ferritin, decrease in the iron binding capacity. Liver biopsy is the most accurate test. Then MRI and the 282Y mutation. It's a genetic disease. Treat with phlebotomy. What are the wrong answers in hemochromatosis? Heart disease is not the most common cause of death. What are the wrong answers in hemochromatosis? That you treat with deferoxamine. Why do you get infertility? Because your testicles become filled with iron. It screws up your pituitary. It screws up your pituitary too. Final disease. Non-alcoholic steatohepatosis. Look at this. There's almost no room for it up here. NASH. Non-alcoholic steatohepatosis. Non-alcoholic steatohepatosis is a fat ass liver. I like big livers and I can't deny it. I like them stuffed with all sorts of iron. I like big livers and I can't. Anyway, so NASH is a liver that's been stuffed up with fat. It happens in people who have diabetes. It happens in people who have hyperlipidemia. It happens in people who are simply obese. It is basically making foie gras out of your liver. There is no treatment for it except to correct your fat ass, to control your diabetes, to control your hyperlipidemia. And the most important thing is it's a diagnosis of exclusion. And when I say foie gras, I mean it. Foie gras is illegal to make in many states in the United States because it's putting a tube down the duck's throat and force feeding the duck until its liver explodes with fat. Then you eat it. However, NASH in human beings is a disaster. It's part of a tremendous obesity syndrome. And the idea is that it mimics alcoholic liver disease, but there's no alcohol. It mimics alcoholic liver disease on biopsy, but there's no alcohol. You treat it by correcting the underlying cause, your fat ass. There's just too much of you to love. NASH. You're exploding with fat. So unless you want to get yourself spread on a cracker and eaten, you got to lose weight, control your diabetes, and control your hyperlipidemia. These liver diseases, it's kind of an experiment actually doing it this way. Look, you have everything in the book. Everything I'm saying is in your book. Okay? It's in the Master Boards book. But this is a different view. It's a different view on your knowledge so that you can make it complete and so you can think like a question writer. What is the most likely diagnosis? What is the best initial test, the most accurate test, the best initial therapy? There's no test for NASH. The most accurate test is a biopsy. You should have to do a biopsy. There is no therapy. I hope you're studying hard because I'm going to tell you for sure humanity needs you. You've been set here to protect this world. Don't let it down.